When a patient walks into an ER with a broken arm, the diagnostic process is straightforward. We can point an X-ray at the problem and see the shattered bone glowing right there on the screen. Psychiatry doesn't have that luxury. There is no blood test for clinical depression. You can't put a patient in an MRI machine to spot a high-contrast cluster of anxiety. Complicating things further, the raw materials of mental illness are universal human emotions. Every person on Earth experiences stretches of deep sadness, moments of panic, or days where they struggle to focus. If everyone feels terrible sometimes, how does a doctor definitively draw the line between normal, everyday suffering and a treatable medical disorder? For clinicians worldwide, the answer is housed inside this textbook, the Diagnostic and Statistical Manual of Mental Disorders, published by the American Psychiatric Association, currently in its 5th edition, text revision. Because the mind is invisible, this manual acts as a translation device. It forces the chaotic, highly subjective experience of mental distress through a strict filter, turning it into a clear, standardized medical language. Arriving at a psychiatric diagnosis relies on a rigorous mechanical exercise in pattern recognition, rather than intuition or guesswork. The first step in this process is symptom clustering. In psychiatry, displaying one single symptom is never enough to qualify for a diagnosis. This diagnostic grid for major depressive disorder illustrates the concept. The manual lists 9 highly specific criteria, things like changes in sleep, loss of energy, or diminished interest. To be diagnosed, a patient must actively check at least 5 of those boxes. Checking the boxes is only the first hurdle. Next comes the duration filter. For depression, those 5 symptoms must be present nearly every day for at least 2 straight weeks, filtering out temporary mood swings. Then, the clinician applies the exclusion rule. They must prove that the symptoms aren't the results of an external factor, like a physiological thyroid issue or a side effect from another medication. These consecutive filters act as guardrails. They ensure that a patient is only diagnosed when their distress is internally generated and statistically persistent. Even if a patient meets all those statistical thresholds, there is still one final barrier to clear, and it relies entirely on the patient's lived reality. It is the ultimate, non-negotiable rule in the manual, the criterion of clinical significance. Clinical significance mandates that the symptom cluster must cause substantial distress or active impairment in social, occupational, or other important areas of a person's life. This separates a manageable behavioral quirk from a debilitating illness. A patient might be highly organized or compulsive, but if that compulsion doesn't cost them their job or destroy their relationships, it doesn't meet the threshold for a disorder. The severity of a mental illness is measured by the friction it creates, the precise ways an internal struggle physically stops a patient from functioning in the external world. Reaching this final, objective classification moves the patient's experience out of the realm of private struggle and into the landscape of organized medicine. Once a condition is officially coded, it triggers a mandatory sequence of support. Insurance providers approve coverage, specialized clinics grant access to evidence-based therapies, and doctors gain a clear, research-backed protocol for medication. Keep in mind the TR, or text revision, tacked on to the end of the manual's current title. It serves as a reminder that these categories are not infallible laws of nature. The manual is a living document. As our understanding of neurology and psychology deepens, the psychiatric community constantly debates, revises, and updates these criteria to match the latest scientific consensus. Psychiatric diagnosis is an ongoing, self-correcting endeavor. It is our best attempt to draw boundary lines around the limitless variations of the human mind, giving us a shared language to locate suffering so we can finally treat it.